Hello, Knee Sig. My name is Brandon Schmitt, for those of you who don't know me, and I'm the chair of the Knee Special Interest Group, and I'm excited to be here with you today for the Ask Me Anything Hamstring edition. It's fun to be on the receiving end of this time. I want to thank Chris Lefever, especially for putting all these together. This is a lot of work, and he takes a lot of time to curate these and put these together and field the questions. So, Chris, thank you. I really appreciate all the work you do with that. So without further ado, we'll start with a question from Chris himself. You earned the right to go first here, Chris. And you asked, can you, in your own words, describe what hamstring eccentrics in the lengthened state are and the importance of including them in a comprehensive hamstring rehab or injury reduction program? This gives me an opportunity to go over some of the research that we did on hamstring strengthening. And this project started probably about a decade ago. And we were finding that a lot of our acute hamstring injuries were going back, and we were having a fairly high level of recurrence. And it's pretty consistent with what we see in the literature. Depending on the sport and the study, sometimes it's as high as 1 in 3 in sprinting sports such as Aussie rules, football, and rugby. Very high numbers of re-injuries. So we said there's got to be a reason for this, and we started to kick some ideas around at our research roundtables. And we had the idea, because the hamstring, in theory, works as a braking mechanism during the sprint phase. And when the knee is extending out into extension, that the hamstring has to work eccentrically to break the shank eccentrically. And maybe that these athletes were going back and they didn't have sufficient strength. And we came across an article by Broderick, and what they did is they looked at athletes who had a previous history of hamstring injuries, and they put them on a dynamometer, and they found that they did in fact have a significant difference in strength in a lengthened position. So in the mid-range they were okay, but they really dropped off when the hamstring muscle got longer. So we decided that we would come up with a research study where we actually trained athletes with hamstring injuries in this lengthened state position. So what we did at our institute is we had these athletes come in, and in the latter phases of the rehabilitation program, we did what we call lengthened state training. And we did this using the Biodex, where we put them in hip flexion. So they sat on the Biodex, they put their hip up at about 120 degrees of flexion, and then we were able to move their knee essentially into a fully lengthened position until they were met by soft tissue resistance from the hamstrings being in full extension. And we trained them on the Biodex in that position in a isolated eccentric. So we set the machine to passive, and it takes them through that arc of range of motion at the lengthened state in hip flexion, and we train them like that. And what we did is we tested them after that, after the cessation of their rehabilitation, before they returned to sport. And we do what's called mapping of a length tension curve. So we look at their strength in relation to the knee flexion angle. And what we found is that all those athletes that completed the course of rehabilitation were able to fully restore their lengthened state hamstring strength. And of the group that were compliant, of the 40-something athletes that were compliant, we had 0 re-injuries. Of those who were not compliant, we followed up with those athletes and we tested their strength. And what we found was fairly consistent with what was found in the Brockett study. In the mid-range, compared to the unaffected leg, they had no significant strength deficit. However, when you looked at their lengthened position, so when the hamstring was elongated, they had significant weakness. And of those group that had significant weakness at their end range, several of them went on to have re-injuries. So that prompted us to start training our hamstring injuries in this, what we call lengthened state position. Now, you don't have to have a big fancy Biodex, although it's nice to have if you do, and you can set it up. Biodex actually has made a piece to accommodate this special position where you can put the hip flexion, the hip inflection, and we'll put some pictures here and video so you can have some idea what exactly it looks like. But you can also do it with just a regular old TheraBand, or you can do it, we'll do it with a cable column. And the way that we do this is we have the athlete lie supine and they pull their hip into maximal flexion. And then we hook either the TheraBand or the cable piece up at their ankle. And they can do a number of things. They can train isotonically, like normal, where they're pulling into knee flexion and controlling the eccentric motion. You can do an isolated eccentric there, where you have either the therapist or you have another athlete pull down, so you're deloading during the concentric phase, so the hamstring can work and come back into knee flexion. Then you load it, and very slowly, eccentrically, you can extend the knee, so you're loading it eccentrically like that. So you don't have to have a big fancy dynamometer, although they're nice if you do. You can train other ways around it. Another option for rehabilitating in a lengthened position is just taking your standard knee flexion machine in the fitness center or the weight room, and instead of having the athlete sit upright, you have them lean forward at their trunk, and you're effectively increasing their hip flexion angle. And what that's going to do is put their hamstrings in a more lengthened position. So you can train them like this as well. Those are some real cost-effective ways to do this. Erik Albarran asks, would you recommend using a handheld dynamometer in measuring hip hamstring strength and lengthened states? If so, what's the ideal position for this? If not, is there another tool that you would recommend besides the Biodex? Thanks for your question, Erik. And the Biodex is a great way to do this. The way that we do it is multi-angle. So we put them in this position of hip flexion, about 120 degrees or so, and then we move the hamstring through different positions by putting the knee at different angles. So we put them in a maximally lengthened position, and we put them in different angles, as you'll see in the picture here that we'll post. And then from this, we can create a length tension curve that shows us their strength throughout the range of motion. As the hamstring gets longer, we can take a look and see what it looks like at the lengthened position. But you don't have to have a Biodex to do it. Another way that we came up with to do this, which I'll also put a picture here so you get an idea, is to have an athlete lay supine, and they're going to pull their thigh tightly into their chest. And then you, as the examiner, can extend their knee as far as they can till you're limited by the tension on the hamstring. You back it off about 20 degrees, and then you can take a handheld dynamometer and you can break them out of that position, and you can see what kind of numbers that you're getting. You can compare it to the contralateral side to give you some idea. This will give you more of a lengthened state strength measurement. You can do this if you don't have a handheld dynamometer. You can do it as a manual muscle test. I would recommend having some kind of objective way to measure it more than a manual muscle test, but it's better than nothing. And at least it'll give you some idea if an athlete has any apprehension in that position, because they should be pain-free in that lengthened position at the very least before they start their higher level rehabilitation and beginning stages of return to sport. The next question comes from Chris Juneau, and he asks about the kinetic variables we're using in relation to these lengthened positions. Chris, what we're using on the Biodex is Newton meters. So we're measuring torque, and we measure it at different angles. And from there, we can make a length tension curve. And we'll post that on the video so that you can see what that looks like. And then we can use that to compare to their uninvolved side. We considered rate of force development, but that's something that is not as reliable as far as testing. And at the time of doing this, we really weren't ready to use that as a measurement. So we went with isometric testing because from a muscle testing standpoint, that's the most reliable method. And so we were able to do that and effectively generate the length tension curves using that. Brandon Jackson asks, why eccentric training? He says that eccentric training is important, especially during running, because they're slowing the shank down. But eccentrics are typically done at heavy loads. And at what point, if any, do these eccentrics happen at the higher speed? In the gait cycle, do they just slow the tibia down from relatively high speeds? Is this where you just practiced sprinting? Is it too high of a risk versus reward? Thanks for the question, Brandon. In our training, in our research, in the rehabilitation and lengthened state, and the way that we train them now is generally about 20 degrees per second on the Biodex. And we do this because we find that we have better compliance with this. We're also able to get more time under tension at 20 degrees per second. It gives the athlete a lot of time to resist. We could have the folks over at the Sports Performance SIG, give a nice 3-hour lecture on time under tension. And I think I've seen some stuff buried in their Mobilize feed. They've done some really great talks over there, and we can get them involved with time under tension and explaining that and the theories behind that and some of the controversies. But we wanted to go at a slower speed when we trained them. That being said, I have played around with going at faster speeds, 30, 40. I don't go much faster than that because I find that when we set it in passive mode and we do that, we're not getting good contractions. It's too fast for the athlete to really be able to forcefully generate hamstring activation. And yes, it is true that when we run, it's very fast. It's much faster than 20 degrees per second. You wouldn't be moving very fast down the field if you did that. It's several hundred degrees per second when you're in a sprint. And this is something that we're not able to replicate on the biodecks, even if we wanted to. And we're going to top out around 300 degrees per second or so. I mean, it's equivalent to baseball, where you're throwing a baseball and it's thousands of degrees per second at your shoulder, the movement. And you're not going to be able to come anywhere close to recreating that. And if you really did want to recreate it anyway, you might as well just have them go out and sprint on the field. So we're doing it strictly from a strength, and there's certainly a neuromuscular component there too, but we're trying to increase their ability to generate force throughout the range, and specifically in a lengthened state position. So when the hamstrings are lengthened, that's what we're really trying to train, and we use the biodecks to do that. Also, as I mentioned earlier, in the rehab, you can do it in a number of ways. You don't have to have the biodecks. You can do it with TheraBands. That's probably where, if we play around with speed in the lengthened state, that's where it is, where we do little pulses. We get a lighter band and we have them pulse very quickly while they're holding their thigh to their chest, just like we would when we train them. So we pick up the speed a little bit there. And then the speed really comes when we start to progress through the rehab and we go through the return to sprinting program and doing some more plyometric stuff. But as far as the biodex itself, 20, 30 degrees per second. Next up, we have a question from Mike Mullaney, who asks what outcome measures we're using. Mike, thanks a lot for the question. You asked about our patient-reported outcome measures. Generally, for acute hamstring muscle injuries, we're using the functional assessment of hamstring injury, and that's known as the FASH, F-A-S-H. And there are 10 questions on that. It asks things about jogging, running, hamstring stretching. So we use that to give us a little bit more of a nuanced, subjective report from the athletes. So we don't really have any cutoff score there, but it's just to give us an idea. And oftentimes it's just to further our discussion with them as a part of the rehab. We can give that to them. We can really pinpoint some areas and see where they're lacking and what they're feeling and what's going on in their head. There are other outcome measures for insertional hamstring tendinopathy. There is the PERTH hamstring assessment tool. Probably the best acronym in sports medicine is PHAT, P-H-A-T, and that's for proximal hamstrings. And there's another one, the Victorian Institute, who does all the VISA A for Achilles you're probably familiar with. There's a number of them. There's also the VISA H, and this is another way to monitor your progression with proximal hamstring tendinopathy. They tend to be a little more useful for the tendinopathies because it gives you a better idea where you're at as far as your rehab, especially because with the tendon conditions, you can do more with pain. You can play with pain. You can rehab harder with pain. We've seen that in some of the literature out to date, where we're not necessarily going to do that with an acute muscle injury. So those are good to keep tabs on where you're at as far as your progression, and they help you make your return to play decisions as well. Katie Colgan asks, what do we do differently when considering insertional versus more distal hamstring tendinopathy? Thanks for your question, Katie. I'll start by saying in general, hamstring tendon conditions are going to be treated fairly differently from our acute hamstring muscle injuries. The hamstring tendon conditions we're going to treat just like we do any other lower extremity, with the same principles as other lower extremity tendon conditions. And there's not a ton of research on hamstring tendinopathy specifically, so we have to use the research done on the other tendons like Achilles and patella, and we use those principles. So that being said, where we start off with that are the isometrics, and we like the research that Ebony Rio's group did a few years ago that got a fair amount of traction, and it's been replicated since with the long hold isometrics for pain. And the initial study they did was on volleyball players, where they had them do an isometric contraction for quite a while. I think it's 45 seconds. And there's been subsequent research out that showed you don't have to do for that long. You can do less time, but you still get the same analgesic effect essentially from those. So that's where we start. We do something like a double leg long lever bridge, and we can progress that to a single leg bridge, and then we move on to eccentric training, some isolated eccentric work. We'll do heavy slow resistance, and we're using the same principles for other lower extremity tendinopathies. From the progression goes from Stanish and Kerwin, who really did some of this initial tendon work, up through Alfredson, who started the heavy resistance work using the loaded backpack for Achilles. And we just take these principles and we apply them to the hamstring tendon. Now, the difference between distal and insertional hamstring tendinopathy is that for the proximal or insertional hamstring tendon pain, we're gonna maintain a neutral hip position, meaning we don't want to get into a lot of hip flexion. And the reason for that is when you get the hip into flexion, you're effectively increasing the compression of the proximal hamstring tendon on the ischial tuberosity. And this is not a position that's comfortable, and it's going to aggravate somebody with this condition. And you'll know this just because when they come in and they talk to you in your subjective report, they'll probably mention something about sitting. So for example, if you have somebody with a proximal tendinopathy, one of the most painful things will be sitting on a hard bench. So the patient will come in and say, I sat on the bleacher this weekend for 10 minutes and I was screaming at me. Or I can't sit in the car for more than 15 or 20 minutes before I get this searing pain in my butt where the tendon is. So we don't work into those, at least initially, until we build up and get further along in the rehab. So we try to keep the hip mostly in a neutral position for the rehabilitation, and then we apply those other principles with that heavy slow resistance, and we go from there. There was a great study done by Cushman and JOSPT, and this was back in 2015, where they had the athlete do a retro treadmill where they were fighting the tread and the tread was giving them the resistance. And this was just a single case, but anecdotally we've started applying this to our patients, our hamstring insertional tendinopathies, and we've had really good results with it. So if Cushman, if you're listening, or anyone in your group, or anyone knows anyone in that group, you really need to do a bigger study, because I think you're really onto something there. It's a very simple but brilliant idea. So we'll link to that paper as well, because that's definitely something you should be trying with your proximal hamstring tendinopathies, because I think there's some really good results to be had there. And it's very simple, very easy to do, where you can easily tell your athletes, look, you got to do this several times per week. You can't make it into the clinic because all you need is a treadmill. And they're going to have one at the university, at the institution, wherever they're at, and they can get on and do that a few times a week. Erik Albarran asks, have we seen a decrease in recurrence of hamstring injuries when using the H test as criterion for return to play, and what other criterion are you using to make this decision? For those of you who may not be familiar with Assling's test, essentially what they did is they had an athlete lie supine, and they put a knee brace on the affected side so they couldn't get any knee flexion, and they held the unaffected leg down, and they hook them up to an electric goniometer, and they prompt the athlete to kick that straight leg up as fast as they can and as high as they can. And they're looking at what speed they can come up with, and if they're having any apprehension when they do that, and they can compare that measurement to the contralateral side. It's a very good test in my opinion. However, most of us don't have an electric goniometer, I know we don't, that we can readily use. So we do the poor man's version of this, which is basically I have the athlete lie down and hold their leg, and then they kick their affected leg up as fast and as high as they can. And so I'm looking at a few things. I'm looking at how fast, just eyeballing, how fast they can do it, whether or not they're able to keep their leg straight, and if they have any apprehension. So I'm looking at them, I'm watching them, and then I ask them afterwards how it felt. And then I take this and I compare it to the other side. I'm really looking for them to be able to do that at equal speed, distance, and without any kind of reservation or apprehension when they do that. This also can be done in standing, where you do it like a Rockette style kick, and you have them keep their leg straight, and you just have them kick up as high as fast as they can with a straight leg. And this is something you can do on the field, and you compare it to the other side, and you're looking for any kind of apprehension, see if they don't get it as high or if they're not doing it as quickly. So this is something that we do use in our return to play assessment. Another big piece for us is looking at strength. And as I mentioned previously, we look at strength in the end range. So we're particularly interested in what their strength is in a lengthened position compared to their contralateral side. And we use this to help make our decision as well. And obviously they have to go through their range of motion and be pain-free. But an important thing to consider is that this is not a dichotomous yes or no type of decision where either they're playing or they're not playing. It's a very graduated return to play with hamstring muscle injuries. So we're going to put them back gradually, incrementally. We're going to start with on the field doing some sprint work and then increasing the sprint work. And depending on how they feel, it's depending on how they progress. So for example, you may start having them do a 20-yard sprint at 50% max effort with a 5-yard acceleration and a 5-yard deceleration. And you have them do a number of trials like that. And when they can do that, you have them go with 60% or 70%. And then you make the distance they're sprinting a little bit longer. And then you can decrease their acceleration and deceleration times. There are several of programs actually out there. I know there's one by Slider, and that group that came out with some, and I think Rod Whiteley and Aspetar have a return to sprint program. So there's numbers out there you can try and create your own. But the principle is that you're not just cutting your athletes loose to go out and start sprinting and return to play. They have to go through a number of steps, and they have to be ready psychologically as well. So you're taking all these assessments into account when you have them return to sport, but not competition. And when you're confident with their sport-specific demands and they meet your objective metrics, like your lengthened state strength and your ASC-linked H test and you're palpating for pain and you're satisfied with all those, then they can return to sport, return to competition fully after meeting your criteria. There are other simple clinical tests that you can use. You can do the M-fake, which is basically, I'll put a picture of that. We're just having the athlete in several positions and you're looking at their motion as they lay there, and the pictures will give you a better idea. But there's a number of tools. The big things though for us are lengthened state, not having apprehension and having progressed through a full return to sprint and then a sport-specific movement, and demonstrating their ability to do that, do it with confidence and doing it without any kind of pain before we'll really cut them loose and to compete at the highest level. Michael Reeves asks us, does the location of the hamstring injury or the chronicity of the injury affect treatment? As far as the location of the injury, the short answer is no. The long answer is a little bit more nuanced. So we'll start with some of the previous research out there. Carl Aspling and his group did show that the distance from the ischial tuberosity has an effect on return to play, but this is more with regards to proximal injuries, and it's not taking into account the muscle tendon junction, the belly injuries, those acute hamstrings. What we found in our literature is that the length of the injury matters. And what we did is we came up with something called hamstring mapping, because like many of you, one of the first questions we get from coaches and athletes and parents is, okay, so he's injured and my son or daughter, I'm out. How long before I'm going to go back? My coach wants to know. We need to plan for when I'm going to be back. And that's a tough question to answer, because we looked at literature and we see some of these prognostic studies and some of these return to sport, and the window, the variable is very big. It's looking plus or minus 30 days. I mean, you're talking 2 months, so that's not any kind of helpful information for the players or the coaches. And there are some good studies out, some very good studies. Jacobson, for example, in BJSM in 2016, they looked at a number of clinical variables, I think 10 to be exact, and looked at them the day after the injury and 7 days out from the injury. And what they did is they did a regression analysis, and they found that if you plug in these variables, 10 of these variables, it'll come out with a number that gives you a pretty good idea of when you're going to return to play. And this is a very effective algorithm, but the challenge with this is to collect all these clinical variables at various time points is not only very time consuming, but it's not practical. Certainly at the high school level, probably at most college levels, you're not going to have the ability to do this. So what we wondered was, okay, is there another simple metric that we can use to have some kind of prognostic value, so at least we can give our athletes and coaches a ballpark figure of when they're going to be back. And what we did was we looked at tenderness to palpation. And the way that we did this is when we had an athlete come in, we started and we did this initially on their first eval, and we did it subsequently through each stage of the rehab progression. We remapped them, and we found the area on their posterior thigh that was most tender. and then we would palpate somewhere, either the calf or the other side, and say, okay, this is what pressure feels like. And then we would go in each direction from that point of most tenderness, and we'd go one thumb breadth at a time. We'd push and we'd say, okay, tell us, is this pain or pressure? And they'd say pain. And you go up the next breath and they'd say pain or pressure. And you do this until they got to the point where they said it was only pressure. We would delineate that mark, and that would be our limit of pain in that direction. So we would do this distally, we would do it proximally, we would do it medially, and we would do it laterally. And that gave us a total area of tenderness to palpation. And then we would have the athlete go through a rehabilitation process, and we would send them back to play when they met our criteria, as I just mentioned in the last question. And we went back and we looked to see, okay, what marks are important, or what's prognostic. And we found that the width wasn't, and the total area wasn't, but what was quite prognostic was the length of tenderness to palpation. And I'll actually put a link on here. We'll give you the algorithm that we did, but when you use the regression analysis with age, it actually works out pretty good. We have a very high R squared, so like 70.72, so we can actually explain a lot of the variance with palpation, the length of tenderness to palpation, and age. So it's something very simple. The next time you have a acute hamstring that comes in, you're gonna do this palpation technique. You're gonna measure it as a percentage of their posterior thigh from their ischial fold down to their popliteal fold. And it'll give you a number of when you can expect them to return to play based on our study. So at least it's something that you can give an athlete as far as prognostically to go back. As far as location, we broke it up into quadrants, and we looked at, okay, if you have this more proximally medial or distal lateral, the quadrants didn't seem to matter where. It was only the length of the tenderness to palpation that gave us the prognostic value. Kelcie Wittman asks, what strategies or tools do you use to assess and address lumbopelvic stability with hamstring injuries, as pelvic posture has an effect on length tension of the hamstrings? I'd like to point out that Kelcie is the vice chair of the NESIG. Kelcie, thanks for everything you're doing for us here at the NESIG, and thank you for your question. I'll start off by saying that yes, lumbopelvic position, or pelvic position in general, does have an effect on the hamstrings, meaning that when you're in an anterior tilt, you're going to have a little bit more tension on the hamstrings as far as putting in a lengthened position. However, for the purposes of rehabilitation and training, I don't take this into consideration much as far as lumbopelvic stability, which I'd like to say is a much better term than core, which is kind of a challenge to hear in a rehab setting. But we'll start by saying it's not even defined. If you look across the literature, there's not really a universal way to define lumbopelvic stability. And because if you can't even define it, it becomes more of an unmeasurable construct. And so therefore, it's hard to measure it, know if you're having an effect. As far as I know, there's very little in the literature about it, and looking at using it either as an intervention or a measurement tool, which makes it hard to really make a suggestion as far as its implications for rehabilitation with regards to hamstring muscle injuries. I would say that it's probably best suited for early phases of rehab, especially when you have acute hamstring muscle injuries that aren't able to do a lot, or even if you have a tendinopathy who's doing mostly isometrics. It certainly doesn't hurt to have them work planking and do some other things that are going to get some glute muscle involvement, some abdominal involvement, and tying all those muscles together. But there's not a ton of literature looking at lumbopelvic stability and positioning. That's not to mention the fact that when you're out there running on the field, you're not going to be able to control, you're not even going to think about what your pelvis is doing in space anyway. When you're going for a loose ball or somebody's coming to run full steam and try to knock you into next year, you're not going to be thinking about whether you're in posterior or anterior pelvic tilt. You just have to go out there and to be able to perform. If you're interested in this topic, there's actually a very good commentary that was written by Tony Shield and Matt Bourne, and we'll post that here. But they did a very nice job of summing up some of the small sample literature that does exist, but they really shine a nice light on trying to define this construct and its application in rehabilitation. So check that out if you're really interested. There's some good information there, and they did some nice work with that. Graham Wade asked us if we use BFR during hamstring rehabilitation. Graham, thanks for your question. I know BFR is all the rage right now, and has some good and growing evidence behind its use, and from a theoretical standpoint, certainly makes sense, and mostly in regards to ACLs. We've seen a lot of it in knee injuries. I have not used it for hamstring muscle injuries, and I think it'd be a really great thing to consider. I think, Graham, you've just volunteered yourself to do some clinical research studies here. It would be great to see the application of this as far as expediency and return to sport, and whether or not that has any effect in re-injury rate and across the board. That would be a great study that I'd love to see you undertake. But right now I haven't. If anyone is using it, that'd be great. I'd love to know how you're using it and what kind of results you've had. It'd be something good to get a discussion going. I'd like to consider and applying it to my rehab. I certainly haven't seen anything in literature to date looking at blood flow restriction with regards to hamstring, so we could be onto something here, Graham. So follow up with that and consider doing a little bit of research on your own. Next question is from Andrew Broderick, and it's too long. I'm not going to read it here, Chris, so you can just post part of the question here. But he was asking about Nordic hamstring curls at the inclines. Andrew, thanks for your question here. And I actually haven't seen this particular study as of yet. There's a lot of good research on Nordics. Certainly, if you're not having your athletes do them as a prevention measure, that every athlete in any sprinting sport should be doing this as a part of their preseason training and even in-season training. And there's lots of literature out there showing that this really does work as a prevention strategy. So I highly recommend that you push all your coaches and sprinting sport athletes to apply this, because despite the good work that this does, that the level of implementation is very low. There's been studies looking at this across European football, and it really works, and most clubs aren't using it still. So as clinicians, we can do our part is really to push this. Graham, as far as your question about our experience training at longer hamstring lengths, we talked a good bit about doing that earlier in this Q&A. I think one of the big changes that we can't measure clinically all the time unless you have ultrasounding the ability to do it is by training at muscle length, at longer muscle lengths. Not only are you going to increase the strength at a longer length, but you're also going to see an increase you're going to see a change in pennation angle at the muscle itself. And there's a growing body of literature that's quite convincing about looking at these muscle changes in the anatomy and the architecture of the muscle. So the way that we train really has an effect on the muscle architecture, and this in turn seems to have an effect on re-injury rate. So it's a multifaceted components of our rehabilitation process, and we're looking to increase strength and increase speed and decrease our amortization phase and all these little things. But I think it ties down a lot to the architecture of the muscle, and that's the way that the literature is going. And I think that's why we're seeing such effectiveness with both Nordic hamstrings, but in lengthened state, and we're seeing changes when you change that angle at the hips as well. So you definitely want to work different angles, and don't forget to do your lengthened state training so that you can make these muscle architecture changes in your athletes. Because at the end of the day, that's really what we need to do, is get them back as fast as we can, but make sure that we can bring this re-injury rate that's so very high with these injuries that makes them so challenging. We can bring that down by really prescribing the correct rehabilitation. Well, gang, that pretty much sums it up. I really thank you for your questions. I thank your involvement in the knee sig. If you've paid attention this long, continue to get involved. I would love to answer more questions or have more discussions on hamstrings. You can get it going on Mobilize. You can reach out to me. I think this is a big, challenging topic that professionally we still struggle with, because we do see very high rates of re-injury, and it's something we just haven't quite figured out yet. So we're still working on it, and it definitely warrants a good discussion so we can keep it going. And thank you for your involvement. Thanks for paying attention. And I look forward to a lot of great things from the Knee Special Interest Group.